Good afternoon. It's a pleasure to be with all of you. Uh, the overall theme of this year's webinar series is controversies in perinatal substance abuse, the kinds of questions people need answers to but don't want to talk about. And I've selected that overall theme because there is so much out there that is still an issue. And even if you pick up the literature, the research literature today, you'll find ongoing arguments and conflict. And one really good example of that is this topic of diagnosis within the fetal alcohol spectrum. Now, to really understand this, I think you need a historical perspective. As most of you know, fetal alcohol, or the danger of alcohol use during pregnancy, was understood in biblical times. This is from Judges, chapter 13. Behold, thou shalt conceive and bear a son, and now drink no wine or soft drink. Or strong drink. Aristotle even wrote about alcohol use when he said, foolish, drunken, or harebrained women most often bring forth children like unto themselves. Not very politically correct, but that was Aristotle. Fast forward to the 1600s, during the gin epidemic, William and Mary, best known for the Bill of Rights, also were the first to recognize the taxing potential for alcohol. Dutch courage had been discovered by British naval sailors when they were supporting the Dutch during the War of Independence in 1568. But William and Mary wanted to increase taxation capabilities in England, and so they began to tax imports of liquor from other nations and gave an advantage to the production of British gin from what they called good English corn. That was in the 1600s, but then soon after, between the period of 1720 and 1751, alcohol was looked upon as the degradation of society. So you can see how fast it began to have an impact. In 1725, during that same period, the College of Physicians in London wrote a document that they sent to the British House of Commons that alcohol, quote, too often is the cause of weak and feeble children, end quote. So the College of Physicians recognized that in the 1700s, but you have to look to more modern times to understand the ebb and flow of the politics around alcohol. Of course, in the 1920s and 30s, there was the temperance movement, but that ended in the mid-1930s. The next really significant occurrence was, when it comes to alcohol use, was World War II. And what happened during World War II, the men were going off to war, and women were left to move into the workplace. And the producers of alcohol didn't miss that opportunity and began actually advertising alcohol to women for the first time. By 1946, apparently women's use of alcohol was growing enough that the Journal of the American Medical Association felt like it had to come out with a statement about alcohol use during pregnancy. And this is what they said, quote, the offspring of alcoholics have been found to be defective not because of alcoholism of the parents, because of the parents themselves came from a defective stock. So what you see here, in contrast to the College of Physicians in the 1700s, recognizing alcohol's impact on pregnancy and the child, the Journal of the American Medical Association denied that impact. In the 1960s was the reproductive revolution, of course, the development of the birth control pill, and the woman's movement. So against that background of especially wine and beer drinking being socially acceptable among women, was the first mention in the modern literature of children affected by alcohol. And this report came out of France. Paul Lemoine, in 1968, he described 127 children born to alcoholic women, and he noted the facial abnormalities and the cognitive deficits, especially a low IQ, hyperactivity, and developmental delays. Now, notice he didn't say anything about growth. This report was roundly ignored both in France and in the United States and other countries. And so it pretty much went into the wayside, and no one was much concerned about alcohol use in pregnancy. In 1972, Udeland published an article that described 12 children who were born to alcoholic mothers. And notice here that he did not describe any facial features, but talked about the growth deficiencies and the mental disabilities. Against this background, and in preparation for the landmark article that first fully described fetal alcohol syndrome, this was all occurring against the background of Roe versus Wade. And that was, of course, the Supreme Court ruling that introduced the concept of fetal rights and asked a question: what role does society have in regulating reproductive issues? Now, of course, these are two questions that continue to this day, but think of that as the background for the publication of Smith and Jones' article in 1973, published in Lancet in the United States. It was a study of only 8 children, but all of their mothers were alcoholics, and 4 of the children looked very similar in that they had growth deficiencies, abnormal facial features, microcephaly, that is a small head size, and significant developmental delays. So this article is noteworthy for the fact that it really provided the first full description of what Smith and Jones termed fetal alcohol syndrome. Now, what I'd like to show you as we go through this is that the evolution of the diagnosis as it occurred against the backdrop of the times and social movements, the diagnosis slowly has been moving from one of structure, that is looking at the face and at the growth patterns, and really looking more toward the behavioral and cognitive difficulties. So a term, fetal alcohol syndrome, didn't seem to address this issue of function, and so the term fetal alcohol effects was developed. Now, the problem with fetal alcohol effects as a diagnostic term was that it was very poorly defined, and the very authors that had developed the term fetal alcohol syndrome soon realized that fetal alcohol effects was being misused, and there was a lot of misclassification. And so the term fetal alcohol effects was discarded. The first real attempt to try to put all this together was in 1996 when the United States Institute of Medicine published guidelines. And they published 4 categories of diagnoses within what we now know as the spectrum. There was fetal alcohol syndrome with and without confirmed prenatal alcohol exposure. And then there were 3 further diagnoses, all of which required confirmation of prenatal alcohol exposure. Partial FAS, also known as FAS with normal growth. ARND, alcohol-related neurodevelopmental disability. And then finally ARBD, alcohol-related birth defects. Now, what you'll notice here is that we are beginning to fall into the alphabet soup. There have been several attempts since the Institute of Medicine publication to try to figure this all out. And from 1997 through 2004, Astley and Claren were working on the 4-digit diagnostic code. Now, the advantage of this coding strategy is that it provided a standardized and very rigid approach to measurement. They included 4 key diagnostic features, each of which was independently assessed. So this was the good news. The bad news from a clinical practice perspective is that if you use the 4-digit diagnostic code, you end up with 256 possible codes subdivided into 9 unique diagnostic categories. And although this strategy has the great advantage of being research-based, it has just not proven itself useful on a daily basis for practicing clinicians. In 2005, Hoyme et al. Updated the Institute of Medicine criteria. The advantage of this was they defined more clearly the diagnostic requirements for ARBD and ARND, but to the chagrin of many researchers and clinicians, they relaxed the facial findings and the structural CNS impairment. Now, we'll get further into exactly what those things are, but just realize they took almost what some people considered a step backwards and disregarded any diagnostic criteria for the diagnostic and behavioral deficits. In 2005, the Canadian Diagnostic Guidelines were first published, and this was a very valid attempt to integrate the Institute of Medicine's guidelines with the 4-digit diagnostic code. In the midst of all this, the federal government and an appointed committee came together and developed the term fetal alcohol spectrum disorders. First of all, please note that this is plural. The term being plural reflects that this is not a diagnosis. There is no such thing as a diagnosis of fetal alcohol spectrum disorders. It is an umbrella term that describes the wide range of effects that can occur in the individual whose mother drank during pregnancy. And the effects can include physical, mental, behavioral, and/or learning disabilities with possible lifelong implications. That's a direct quote from the publication. But what we have now is FASDs as an umbrella term and various diagnoses under that umbrella. FAS, partial FAS, ARBD, ARND, and then a new term that just came out through the publication of the DSM-5, NDPAE, neurodevelopmental disorder with prenatal alcohol exposure. There are 2 things I would like you to note on this slide. One is the wide array of the alphabet soup I mentioned earlier. The second is, note that I put an S at the end of FASD. This is because people are using FASD as a diagnostic term, and I use the S to emphasize that it's fetal alcohol spectrum disorders. It's been interesting in watching journal articles in that at first FASDs was being written in articles as the plural. But now if you look at articles, you'll see that it's just FASD. And I think this is adding to the confusion. So as I mentioned, the DSM-5 in 2015 described neurobehavioral disorder associated with prenatal alcohol exposure. But notice it's in the chapter titled Conditions for Further Study. So it is not included as a diagnosis in the DSM-5. Some important points. The DSM-5 states that there must be more than minimal exposure to alcohol during gestation, although nobody can quite say what more than minimal exposure actually means. And it focuses on functional neurodevelopment in 3 domains of functioning: neurocognitive, adaptive, and self-regulation. Notice that there is nothing about facial features or growth abnormalities in the diagnostic criteria according to the DSM-5. Although NDPAE is not included as a diagnosis, somehow, and we're not quite sure exactly how this happened, but NDPAE is used as an example of intellectual disability or intellectual developmental disorder, coded as 315.8, so that many are now using 315.8 to use as a diagnostic term under which NDPAE can be filed. There is a lot of controversy around this point. So how do we make sense out of all of this? So what I'd like to do now is take you through the basic diagnostic criteria and then show you a comparison of the different diagnostic schemes that are out there, and then show you how we approach it at NTI. The basic 4 criteria for diagnosis within the fetal alcohol spectrum are, first of all, prenatal alcohol exposure, growth impairment, facial dysmorphology, and neurodevelopmental disorder, which can be structural, neurological, or functional. So those are the 4 basic criteria. Let's look at prenatal alcohol exposure first. To have confirmed prenatal alcohol exposure, most researchers and clinicians agree that you have to have reliable clinical observation of the woman drinking during pregnancy, self-report by the woman or a report from a reliable source, such as a family member, medical records that perhaps document high blood alcohol levels, the woman having been enrolled in alcohol treatment, or other social, legal, or medical problems related to drinking during the pregnancy. And these problems can be reflected in court documents, in child protection services documents, or in the woman's prenatal records. The second is growth impairment. And the growth impairment has to be either current or in the past, height and or weight, either or both, being below the normal range. The third component is the facial dysmorphology. And the facial features include the short palpebral fissures, that is the opening of the eyes, a flat philtrum, and a thin vermilion border. Now let's explain these a little bit further. This is the facies of fetal alcohol syndrome. What you need to remember is that alcohol is a midline teratogen. And so what you get is a flattening of the midface that will produce epicanthal folds, that is folds coming over the middle angle of the eye, short palpebral fissures, a flat nasal bridge, upturned nose, a flat philtrum. Now the philtrum is the area from the bottom of the nose to the top of the lip. The groove that extends from the bottom of the nose to the top of the lip is located in the area of the philtrum. And children with fetal alcohol syndrome will have a flattened philtrum. And then a thin upper lip, small mouth, and receding jaw. And so what you get is an undergrowth or hypoplasia of the midface. Astley and Claren developed a lip philtrum guide. I highly recommend that you purchase this. I think they're $8 and you get them through the University of Washington. If you go to the University of Washington FAS site, I think you can purchase them through that site. Simply you hold the philtrum guide. It's about an 8-inch plastic laminated with these pictures on it, and you compare the child's lip and philtrum. And for a Caucasian child, ranks 1, 2, and 3 are all normal variants. Ranks 4 and 5 are consistent with fetal alcohol syndrome. To meet criteria for a diagnosis of fetal alcohol syndrome, the child must have a rank 4 or 5 lip and a rank 4 or 5 philtrum in most diagnostic guidelines. We'll talk further about this. The only other racial ethnic group that the lip philtrum guide has been developed for are African American individuals. And for this, you can see ranks 1, 2, and 3 all are within the normal range. Ranks 4 and 5 are consistent with fetal alcohol syndrome. I'm sure many of you have seen these kinds of pictures before. On your left is a 6-week-old infant. On your right is that same infant at 3 years of age. You can see the rounding of the eyes, short palpebral fissures, flattening of the nasal bridge, upturned nose, flat philtrum, thin upper lip. These are the classic cardinal features of fetal alcohol syndrome. And then the fourth criterion, the neurodevelopmental disorder. This can present in one of several ways. It can be structural, and I include under structural the small head circumference. That is, when you measure the occipital frontal circumference of the head, or structural brain abnormalities that you can find on MRI, such as agenesis of the corpus callosum. There are multiple other abnormalities that can be picked up on MRI in children with fetal alcohol syndrome. After structural, there can be neurological abnormalities. And a good example of that is a child who has seizures that cannot be attributed to febrile seizures. And the third arena are the functional neurodevelopmental deficits. Now, this can be represented by a global IQ or global developmental score that is outside the norm, or specific deficits in cognitive functioning related to performance, verbal, or spatial cognitive aspects. However, global cognitive functioning can be completely normal, but you can find deficits in neurobehavioral functioning. This can include, for example, executive functioning, learning difficulties, memory impairment, visual spatial impairment. And then under functional deficits, you can get, in addition to cognitive deficits and behavioral impairment, you can get deficits in adaptive functioning. So those are all the various criteria. Now here's where it gets really confusing. I'm presenting the 4 most commonly utilized diagnostic approaches. Across the top of the screen, you see the 4-digit code. You see the most current Institute of Medicine guidelines, the Canadian guidelines, and then the DSM-5. And what I'd like to do is take you across this from left to right for each of the 3 key categories, for each of the 4 key categories. The 4-digit code has a variety of codes that can fall either under confirmed or unknown prenatal maternal alcohol use. The Institute of Medicine guideline requires confirmation of excessive alcohol use or an unknown use of alcohol. The Canadian guidelines require confirmed or unknown, and the DSM-5 requires confirmed more than minimal alcohol use by the mother. So you can begin to see inconsistencies across the different guidelines just with the amount of alcohol the woman drank. Growth, the 4-digit code requires prenatal or postnatal growth below the 10th percentile. Institute of Medicine is the same. And the Canadian guidelines state that it can be pre or postnatal growth below the 10th percentile or a weight to height ratio of less than the 10th percentile. Facial dysmorphology. Now here's where we get into some real conflict. Remember the three key criteria for facial dysmorphology. It's the short palpebral fissures, flat philtrum, and thin upper lip. The 4-digit code requires that the palpebral fissure length be below 3rd percentile and that the philtrum and lip both be rank 4 or 5. And diagnosis of fetal alcohol syndrome under the 4-digit code requires all three criteria to be present. This is the same for the Canadian criteria. If you skip over 2 columns, the Canadian requirements also require all three criteria. However, the Institute of Medicine revision requires only 2 of the 3 characteristics. So any 2 of these 3 characteristics can qualify the child for a diagnosis of FAS. And the 4th criterion, the 4th domain, is neurodevelopment. The 4-digit code requires the structural abnormalities, as I've mentioned before, and that includes a head circumference below 3rd percentile, or a seizure disorder that is not due to febrile conditions, a global cognitive disability, or 3 or more domains with an area of functional deficit that is greater than 2 standard deviations below the mean. So let me interpret that. What that means is you have to have 3 or more arenas or domains of neurodevelopmental functioning, and each of those 3 domains has to have an area of a functional deficit that is outside the norm. The Institute of Medicine, the first 2 criteria are the same as the 4-digit code, but notice that the Institute of Medicine requires that cognitive impairment be at or below 1.5 standard deviations below the mean, or have one area of behavioral deficit greater than 1.5 standard deviations below the mean. So you get a difference here. The 4-digit code requires more than 2 standard deviations below the mean. The Institute of Medicine criteria require 1.5. The Canadian arena is the same as the 4-digit code, but I should point out here that the Institute of Medicine requires the head circumference to be only below the 10th percentile, whereas the 4-digit code and the Canadian codes require 3rd percentile. And finally, the DSM-5 has no growth criteria, no facial dysmorphology criteria, but its neurodevelopmental requirements are much more stringent in that it requires a deficit across each of 3 specific domains: neurocognitive functioning, self-regulation, and adaptive behavior. So what you can see in looking at these 4 diagnostic guidelines, that there is some variance across all 4, and this can affect how a child is diagnosed. The key issues we're facing as we try to make a decision of how we're going to approach this clinically, the key issues are, first of all, alcohol exposure. How much alcohol is too much? We simply don't know. There is no known teratogenic level. And clinically, we tell women and men there is no amount of alcohol that is safe to use during pregnancy. period. There is some good human data as well as animal data that support this recommendation: no amount of alcohol is safe. And I think that's where the statement in the DSM-5 that says more than minimal alcohol use comes from. The second area is the growth parameters. Should the growth be below 3rd percentile or should it be below 10th percentile? 10th percentile in the general population is normal. And anything from 5th to 10th percentile certainly is considered normal growth. Should we hold to the more stringent 3rd percentile, or is it fair to include less than 10th percentile as a impaired growth indicator? Head circumference is the same thing. Is it 3rd percentile or 10th percentile? When considering facial dysmorphology, should it be 2 criteria or 3? And finally, what exactly is the definition of neurodevelopmental deficits? So I'm going to put you out of your misery. I'm going to try to give you an answer. Now, let me just say that this is the approach we have used in all of our research and clinical work. Our criteria, in fact, tend to fall on the more stringent side. And here's our reasoning for what I'm about to present to you. First of all of the guidelines except the 4-digit code were developed by consensus. There is no clear research that has tried to specifically separate out the different guidelines and see what's right. It's a consensus. They're made up of a consensus of experts in the field. Secondly, NDPAE, as defined in the DSM-5, has not been validated. And so, although it gives very specific neurodevelopmental domains that need to be looked at, which I think is very valuable for the approach to assessment as well as diagnosis, we really don't know for sure that it's any more reasonable than any of the other diagnostic criteria. As I mentioned, the 4-digit code is the only research-based approach, but it's really too unwieldy to use on a daily clinical basis. The 10th percentile, as I mentioned, for head circumference actually is within the normal range. FASDs can only be differentiated from other neurodevelopmental syndromes by clear delineation of specific deficits across multiple domains. And as many of you are aware, we published an article in the last couple of years that looked at this question of misclassification and found that children who do meet criteria within the fetal alcohol spectrum, once we did a full evaluation, 85.6% of those children had been misdiagnosed or misclassified. And so that's why I feel like we really must stick to the stricter criteria. And the high rate of misclassification and poor specificity, if the parameters are not tightly defined, is the thought behind that reasoning. So with that reasoning in mind, I'd like to review for you the way we have tried to put all of this together. So our diagnostic approach for research as well as our clinical work. For alcohol exposure history, we take birth mother confirmation, direct observation, kinship reports, medical records, or any other kind of legal or medical records that document the mother's use during pregnancy. One of the difficulties on a very practical basis that we get into is the woman who is reported to us to have used cocaine or heroin or other illegal drugs during the pregnancy, and there's no mention of her alcohol use. We know that the most common form of substance use among women is polydrug use. And from our own research, we have found that a minimum of 81% of pregnant women who use any other drug including tobacco, are also using alcohol. For fetal alcohol syndrome, we will use confirmed or unknown alcohol use history. So if we don't know and the child meets all the various criteria, we will make a diagnosis of FAS. For the dysmorphia, for fetal alcohol syndrome, the children must have all three criteria. Now you'll see, you recognize that this is in contrast to the Institute of Medicine that requires only 2 of 3 criteria. But again, because of misclassification, I do think we have to adhere to the stricter criteria. Growth parameters, to be consistent with all other guidelines, we do use 10th percentile. Below 10th percentile for height or weight in the past or currently. However, in contrast to the Institute of Medicine, we do require 3rd percentile rather than 10th percentile to count small head circumference. In addition, we will use global cognitive deficit or a central nervous system problem through evaluation of 3 domains more than 2 standard deviations below the normed mean. Now we'll talk about those 3 domains in just a moment, but notice we are using the DSM criteria for neurodevelopment. And the reason we're doing this is because it's very clear. It provides a pathway for a comprehensive assessment, and to meet the significant deficits that these children show, requiring something from all 3 domains helps us differentiate from other diagnoses. So for fetal alcohol syndrome, as I said, we require confirmed or unknown alcohol exposure, all 3 criteria for dysmorphia, height or weight below 10th percentile, and head circumference or neurodevelopmental difficulties as noted. Now for partial FAS, we get the same picture in that the dysmorphia, they have to have all 3 criteria, but we do require confirmed alcohol exposure. This is in contrast to some other groups that will make a diagnosis of partial FAS with an unknown alcohol history. Growth impairment is not present, but the CNS difficulties are. So basically, partial FAS is FAS except the child has normal growth. And then the third diagnosis that we will use is ARND, alcohol-related neurodevelopmental disorder. This requires a confirmed alcohol exposure. It requires that the child not have 3 criteria, but the child will have none to 2 facial criteria. But even if they have 2, we will not make a diagnosis of FAS. We will make a diagnosis of ARND. Growth can be impaired or not, but they must meet the CNS requirements. Now, I'd like to talk for a moment about the neurodevelopmental requirements. As I mentioned, they fall under 3 domains: neurocognitive, self-regulation, and adaptive functioning. Now, this is based on the DSM-5. For neurocognitive functioning, many of our children, the great majority in fact, have normal global cognitive development. But where they fall into problems are with the other neurocognitive aspects, including executive functioning. And executive functioning is the ability to plan and complete a task. It's the ability to follow through, to understand sequencing. Learning disabilities, we will count as a neurocognitive deficit, and then memory problems. Now, that's not only problems with long-term memory or short-term memory, it's also working memory. And we find especially that children with alcohol exposure have difficulties with working memory, that is, taking information out of memory and manipulating it so you can use the information to complete a task or complete an assignment. Also, children with prenatal alcohol exposure commonly have difficulties with moving information from short-term to long-term memory. And this, of course, has implications for education and learning. For a child to qualify as having a neurodevelopmental disorder related to alcohol exposure, the child must have at least one element of neurocognitive functioning that falls more than 2 standard deviations on testing below the normed mean. The second arena they must qualify in is self-regulation, and this is where you get into the problems with attention, impulsive behaviors, mood swings, that is, regulating their emotions. So it can be behavioral regulation or emotional regulation. And the third criterion is adaptive functioning. Communication deficits, impaired social skills, abstract reasoning, concept formation. So this is the area that children with fetal alcohol spectrum disorders are particularly vulnerable in. And adaptive functioning is the way you can often differentiate children affected by alcohol from the other diagnoses that may be out there. So again, in order to make a diagnosis within the fetal alcohol spectrum, we use as our criteria that the child must have at least one deficit in each of these 3 domains: neurocognitive, self-regulation, adaptive. Does this really make any difference? To really understand the child and to develop intervention and treatment strategies that work, I think we need strict criteria for diagnosing and following these children. In one study we published in 2010, we looked at a population of foster and adopted children, and we used the criteria I just explained to you to diagnose the children as FAS, partial FAS, or ARND. And then we used multivariate analysis of variance with follow-up descriptive discriminant analyses to ask the question, are there neurodevelopmental differences across these 3 diagnostic groups? What we've found is that all of the 78 children who had been prenatally exposed to alcohol performed significantly worse than the norm across all domains. So they met our criteria for having at least one significant deficit in each of the 3 domains. But what we found is that the children with fetal alcohol syndrome, as opposed to partial FAS and ARND, had significantly decreased weight, height, and head circumference, had the most impaired levels of general intelligence. They were significantly worse on language-based memory as compared to the children with ARND, and they had significantly poorer functional communication skills than children with partial FAS. Executive functioning seemed to be the common thread across all 3 groups as far as the most significant deficit, but children with FAS were significantly worse on sequencing and shift than either the partial FAS or ARND groups. Interestingly, children with partial FAS and ARND were similar in all neurodevelopmental domains that were tested. So this gives some credence to the Canadian system, in which their diagnoses are FASD with the facial features, or FASD without the facial features. Now you'll notice something else about the Canadian system, in that they use FASD as a diagnostic term. That is not the way FASD is used in US diagnoses. So I've tried to lay out a scheme here of how you can approach children as you make the diagnosis of make a diagnosis within the fetal alcohol spectrum. So we're going to start with prenatal alcohol exposure. If it is confirmed that there is no exposure to alcohol, you'll see there is no FASD diagnosis. You don't even have to look at the other features as far as they pertain to alcohol. Now, if there is confirmed exposure, you have to ask yourself, does the child meet criteria for alcohol exposure with one deficit, at least one deficit in each of the three key domains? If the child does not meet criteria for neurodevelopmental deficits, you cannot make a diagnosis of FASD. However, if the child does meet the criteria for a neurodevelopmental deficit, then you ask, does the child have the facial dysmorphology? If the facial dysmorphology is met, you're on the path to a diagnosis of FAS. If the facial dysmorphology are not met, it doesn't matter what the growth is, the diagnosis is ARND. So those are children with confirmed prenatal alcohol exposure, neurodevelopmental deficits, but normal facies. That is ARND. Now, if the child had confirmed alcohol exposure, the neurodevelopmental criteria are met, and the facial dysmorphology criteria are met, then you have to look at growth. Is there growth impairment? If yes, then that child has fetal alcohol syndrome. He has neurodevelopmental deficits, he has facial dysmorphology, and he has growth impairment. That's FAS. However, if he has the neurodevelopmental criteria and the facial dysmorphology, but no growth impairment, that's partial FAS. The third area is if you do not know about prenatal alcohol exposure. If prenatal alcohol exposure is unknown and the child does not meet neurodevelopmental criteria, obviously there is no FASD diagnosis. However, if the alcohol exposure is unknown, but the child meets neurodevelopmental criteria and the facial dysmorphology and the growth impairment, that is fetal alcohol syndrome. Now you'll notice within each of these categories, I did not specifically say what the criteria are. You need to decide that for your own clinical work. However, researchers need to be sure that whatever diagnostic scheme they use, it's clearly spelled out in their article. I do not think that any article related to the effects of prenatal alcohol exposure should be published unless there's very clear information about the criteria used to diagnose children. Now, I'm hoping that this one slide is worth your price of admission. I think it can guide you, no matter how you decide to define your criteria based on all the information I've given you so far. I hope it can guide you clinically in approaching the diagnosis. I think it's the best combination of the Institute of Medicine, the 4-digit code, and the DSM-5 that we have so far. I do hope this information has been helpful. It's a very confusing and controversial arena. There is a lot of back and forth in the research literature, and I do think that we have done harm to the field by creating, again, such an alphabet soup of different diagnoses. But it is what it is, and I think we have to move forward from here. There is a whole long list of possible future research that needs to be done.